Okay, so welcome back, everybody, and everybody online as well. We've got a great breakout session for you with Jane Dacre and Paul Tiffin. And they're going to talk about the UK Medical Education Database. So this is one that's specifically for people who are interested in doing quantitative research and maybe specifically on doctors as well. So I'll hand over to, I don't know who's going first. Is it you, Jen?
Hello. I'm just checking that that everything is working. It looks like it is. So my name's Jane Dacre, and I'm I think I probably was an early adopter of medical education because I'm that old. And I'm going to be the warm-up act for Paul. So my children, watched my career with interest. And one of the things that used to happen a lot in my household when the kids were younger was swearing. And my son said, Mum, I learnt some swear words from you, but Dad taught me how to use them. So here, what I'm doing with Paul is that I'm going to be the warm-up act for Paul. I'm going to tell you a bit about UKMED, but Paul's going to tell you how to use it. So he's much more useful than I am. So UKMED is a unique resource. It's been going for a while, and essentially it is a resource for people who want to do quantitative research related to medical education and workforce. So why should you be interested? And one of the things in research generally is that numbers still in our universities seem to count more than qualitative research. Whatever we think, whatever we say, whatever we believe, numbers always trump, to use an unfortunate but topical phrase. And the effective use of administrative data sets is a growing field that could have huge impact, particularly in this country where we have a National Health Service and we have a lot of national services. And we need to be able to use those data sets for the benefit of students and patients. Although the US is very big, it's got fractured health systems, fractured education systems, and it doesn't bring it all together like we do. So collectively, we could have a breakthrough, and that's where we want to encourage you guys to use the administrative data sets to try and get that breakthrough. But it's complicated. There are all sorts of barriers and things that make it difficult. GDPR, law, privacy, accountability, and we must protect all of the subjects whose data is being used, and that makes it very, very difficult to navigate. So it's been going since 2015, and if you want to look at the published research, just have a snap look at that website. It's a collaboration between a large number of organizations, which is great because you have a great deal of collaboration. It's a complete nightmare to manage as the chair of that collaboration, because there will always be one or two people who don't like what you're doing. So just to give you a bit of an idea about what you could do with big data in medical education, think UK Biobank, which is a repository for people's data and people's biomedical results. And from that, a huge number of positive interventions have come for the health of this country and others. And this is what we want to do with UKMED. These are the data sources that we have. Essentially, from it's all doctors, and maybe it shouldn't be, but from a medical perspective, it's cradle to grave. So we start before people get into medical school, we collect data all the way through their journey, and also have access to NHS payroll data. So cradle to grave. So we want to provide the data to produce evidence-based policy. Those of you that have seen various fiascos along the way will see that we often in medical education say, probably let's have a few more of these, and then a few years down the line we've got too many of these, and oh, let's turn off the tap. It's really hard to do this. To look at selection, are we getting the right people in? What determines success? What determines career choices and career success to help with workforce planning, so we don't have to retrain people. And the key bits of value added. There's a big controversy at the moment being led by some people who know diddly squat about medical education, saying it will be an absolute disaster if we reduce the medical education programme to 4 years. Why? Where's the evidence? Where's the data? There isn't any. So on the advisory board, which I chair, we have all sorts of issues. One is the governance. How does it work? How do you get all of these cats to be herded in the same direction? Do we go for commissioned research for NHS England, or is that collaborating with the devil? We don't currently have infrastructure funding, but should we offer that to build up the basis on which we do the research? What do we do about consent? And that's a really interesting legal problem. The people who hold the data are the GMC. The GMC don't ask for consent for people's data, because legally it's thought that if they do ask consent, they're coercing the people who give their data. So they don't want us to ask for consent because it's illegal. But the BMA say you can't do research without consent. End of story. Stop talking about it, stop doing it. So we have to negotiate documents that allow both to do what they want to. Ethics of research, we're a national database, but if you put in an application for a research project using big data in Birmingham, you'll get a different result than you might at UCL, because ethics committees are local, and there's no discussion other than a vague "we'll play nicely in the sandpit" agreement. Well, that's rubbish, isn't it? That's nonsense in the days when we're trying to pull everything together. So we're working on that. And then, of course, politics, and there's a lot of that about at the moment. But if we could get this right, we'd have a huge impact. Education research has been undervalued. I was just talking about it with Kath now. You know, I left UCL a couple of years ago. It's still undervalued. The things that I was saying 20 years ago to the medical school, which is you've got to value your educators and they've got to support their research, still has not been listened to. But the power of large data sets is something that's going to, with AI and computing and everything going online, is going to be absolutely fantastic if only we can harness it. So the opportunity is there to work with us. So that's telling you a few swear words. Over to Paul to tell you how to use them.
So yeah, I always say workforce education interventions are a healthcare technology. You wouldn't implement a new treatment without appraising it, yet we do workforce stuff and education stuff all the time. And also the other thing is education is governance. It's there to assure good standards for safe, high quality clinical care, but it's rarely thought of as such. And UKMED is part of the answer towards evidence-based medical education and workforce policy. And it is the envy of the world. I get people from Canada saying, how can we set something up similar in Canada? People in Australia say, we want something similar in Australia. So, you know, we've got a real treasure. We're sitting on a treasure trove here, and we don't even know what's under the bed. It's amazing. So I would just, in 14 or 15 minutes maximum, I will just tell you, give you a worked example with some do's and don'ts from my experience of sitting on the research group for about 6 or 7 years and reviewing a lot of applications, some of them good, some of them not so good, and just tell you really what you should and shouldn't think about if you're applying to access UKMED data. Because although it's free to access, there's a cost because the GMC have to employ people to get you data and all sorts of things. And also there's a cost to you, your time and all the rest of it, right? So even if it's not funded, we still have to have high quality applications. So the question, I'm just going to give you a worked example. So the question came up, Health Education England, as it was then, suspended face-to-face processes for recruitment to psychiatry training during the COVID pandemic. Then they were thinking like, that was a face-to-face selection centre. So they were saying, well, is it worth putting back in? And now that COVID's passed, because the evidence from the general practice selection was the selection centre scores didn't add much value to predicting how people did in their MRCGP final clinical skills exam, but they were expensive to run. So should we bother? So that was the question, a good policy question. And they did pay a bit of consultancy money to work psychology group, and a little went to me. So they wanted to know, is it worth putting them back in? So that was the primary question. And the secondary question was, if we put them back in, Who should we use them for? So when you think about a question, it has to be the right question. So first of all, you have to ask a question that if you answer it, it's likely to impact policy one way or the other. It's still relevant because quite often, particularly if projects take a long time, they're not future-proof, they're no longer relevant by the time you get the answer. Don't choose a question that cannot be answered by UKMED, because we do get applications to UKMED where you're never going to answer the question from our data. And again, you get lots of academic type questions sometimes that aren't really that policy relevant. And also we get questions that probably could be answered better through local small data sets, which are a lot easier to get hold of and maybe just of local interest anyway. So you can have a look at the UKMED application. This was P155, and they're all publicly available once they're accepted. So you can look that one up. It provides a summary of what the application was about. And I'm just going to go through the different areas of research scoring quickly with examples. So we score the, I no longer sit on the group, but they still score the research questions. They score the methods, the analysis proposed. They also look at your team expertise, the support in terms of funded and unfunded time, and also your proposals to actually disseminate and get the research out there and hopefully into policy. So in terms of methods, I always say start with a hypothesized causal model, and that should be based on prior evidence theory and common sense. I know causality, the C word, is a bit seen as like almost like a rude word in statistics. But I actually did a causal inference course just over the road, actually, at the London School of Tropical Medicine and Hygiene many years ago. And that's the one thing I came away with, just have a theoretical model about how you think these factors relate to each other. So in this case, based on some previous work we've done in different data, not to do with psychiatry, but other ones, we had a causal model about how the different assessments as part of recruitment worked with each other. So we've got situational different test there, the selection center, the knowledge-based test, the CPS, and our final outcome, which we're interested in, was the CASC, which is kind of the high fidelity clinical simulation exam psychiatrists take as the final part of their membership exam. So you start off with a causal model. And then you have to think very carefully about primary outcome and how you might measure that. And in this case, it was the CASC, that first attempt. And we took the relative score according to the pass mark. And we also wanted to look at the sensitivity of the different selection measures to things like gender, socioeconomic status, that sort of thing. Because again, there's implications for widening access, for discrimination and that sort of thing. And we wanted to see, particularly if the selection center scores added value when predicting the CASC performance over and above the other selection assessments used for both all applicants and also those who scored low on the MSRA, the multi-specialty assessment kind of battery that's used across a number of medical specialty recruitment assessments. So when you're doing that sort of thing, you think, I would say, do create a path model to begin with. Think about how you define the outcome. Focus the approach around the research questions. Don't list a load of outcomes, because often we'd get people applying and they'd have like 7 or 8 different things they were going to look at. But be very clear, a bit like a clinical trial, what your primary outcome is. You can have secondary outcomes, but be very clear about that. And also only include policy relevant variables. So lots of people will throw the kitchen sink at the analysis. And I'll say, well, how is, like, for example, how is gender, why is that gender in the model? Because you don't select on gender, do you? If you're looking at policy relevant questions, you really should be putting in things that are relevant to, say, selection policy. Yeah, it might be appropriate to put gender in, but it depends on your question, really. So managing cleaning of data, this is always underestimated by teams. This is 99% of the work, particularly with UKMED, where the data is a little bit messy at times. It's not always clear what each variable is. We standardize the written scores. Thinking about missing data is very important when selection studies, because if you don't think about the missing data, you will underestimate the effects, because you get something called attenuation of range. So if you can't see an outcome in someone who wasn't selected, that actually distorts the picture. So you have to think about how you're going to impute the data, the missing values, particularly for outcomes. You might start off, we started off doing some univariable relationships. Again, you can look at the paper, which is published now in British Journal Psychiatry Bulletin. So you might start off with something simple, just looking at correlations, univariable relationships. Here we also calculated the effect size for the demographics on the selection measure. And again, I'm not going to go into the actual findings, but you can see here, for example, in terms of situational judgment test performance, International medical graduates did a lot worse. It was very sensitive to where people qualified from. So you can see that little green TIE fighter right at the top, very Star Wars fans, outlier, compared to non-international medical graduates or home graduates. So that's the sort of thing we were looking at, are these measures sensitive? And then you might want to progress to what I'd call a flat multivariable model, where you throw everything into a multiple regression. And we did this here. If you do this, there are some statistical traps, and I don't recommend you just leave it here. But you can see effectively, if you pretend everything acts at the same time, you can see what the independent effects are in a very simplistic way. But then finally, you work up to testing the path model, which is your hypothetical model. So we tested it for all applicants initially, and you can see here, the selection center scores had just as much predictive power to predict the CAS performance as the situational judgment test. Now, that was not what was found in the general practitioners. In GP recruitment, the selection scores had virtually no independent value, which is why they were saying, why are we bothering, right? So they did seem at least as good as the situational judgment test scores for predicting. So that's the first question answered, that they do add value. And then we looked at the low scorers, because again, they often at one point in psychiatry, if you got high scores on MSRA, they didn't bother sending you to the selection center. And this is something that's practiced in Australia as well with the general practitioner recruitment. And so we wanted to look at what the relationship, the independent effect of selection centers were for those who scored low. And that was based on I won't go into it, but that was based on a sort of screening test model where you have a receiver operating characteristic curve and you find the sweet spot for where the best threshold is. And so I found it was 484 points. And so those who scored below that threshold, you can see actually the selection center, if anything, had a relatively more profound predictive effect, predicting the final clinical assessment performance. In contrast, the SJT didn't work quite as well. So that's the standardized correlation coefficient 0.23, which equates to about 4 or 5% of variance, not that much. So you can see actually for low scoring MSRA candidates, you can see there the selection center actually did more work, did more of the heavy lifting. So when doing analysis, do considering how your missing values are managed, and that goes for outcomes as well as predictors. There's a lot of stats papers you'll read that say never predict outcomes. That's nonsense, particularly in a selection study, personnel selection studies. You will get very distorted results if you don't find some way of correcting for the missing outcomes in those who are not selected in. Do consider clustering and dependency. Again, when you're reviewing UKMED applications, people have what we call like hierarchical data, for example, people within medical schools or that sort of thing, and they don't think about how they might adjust for that clustering or dependency effect in data. So also, you might want to think about how you deal with resits, multiple applications. So some rationale, it could be just take the first sitting, for example, or use a multi-level model. But people don't always think about that either. And also do sensitivity analyses. So sensitivity analysis is just checking out if you change something, would your results change dramatically? So here we would always do a sensitive analysis about what would it look like if we only compared the results with full data rather than missing data imputed versus the imputed data. And that will tell you whether your imputed data might be trustworthy or not. So usually in this case, they were pretty much the same. But if they were different, it raises questions about whether by putting in values that were missing, you've actually got sort of distorted results because there's something funny about the way that missing data are missing. Don't slavishly follow the old stepwise regression model for variable selection. Some statisticians believe that stepwise regression is the work of Satan. I wouldn't go that far, but you do sometimes get some misleading results if you do that, because you might miss variables that are what we call colliders or reverse confounders, for example. So I don't recommend stepwise regression. And don't just use listwise deletion. So often software will default to listwise deletion, which means that any row of data where there's only one missing even will not be included in the analysis, and that can reduce your information and it can produce distorted results. And again, don't use just single level models where you've got clustering, say students within medical schools or that sort of thing, because again, that's not appropriate and you might get distorted results. And also people often fall down a bit of a data rabbit hole because there is so much data in UKMED, people get kind of fall down rabbit holes and they forget what the original policy relevant question was, and they start looking at this and that association, and you know, might even engage in p hacking, looking for the sacred p of less than 0.05, you know, so don't do that. So anyway, just to finish off, just in terms of our team, there was myself, who's a domain expert, because I'm a psychiatrist by background, but also a quantitative methodologist. There was Fiona Patterson from Work Psychology Group, who'd been originally approached by Health Education England, who provide the MSRA and did all the recruitment for them. So who's a content expert and also an organizational psychologist, very well known one by background. And also Emma Morley, who works for Work Psychology Group, who again is an organizational psychologist by background. And there's Lewis Payton, who's my lecturer in data science, who helps me with some fiddly stuff. So he did data visualization for this. Though he did the nice graphs using R, which I'm not so familiar with. And I did the other stats. And I also talked to him about rarefied stats matters sometimes. There's also Nandini Chakrabarti, who did oversee the recruitment to psychiatry. She was involved with Health Education England for a long time as a senior psychiatrist involved. So in terms of teams, do identify experts in data management, because data management is 99% of it, not just the analysis. People who know what they're doing in stats software, also domain experts who understand how to interpret the results and make decisions about the data. Don't assume that limited experience in stats, for example, basic SPSS use allows essential data management to be done, because sometimes you have to merge and join data sets in a particular way. And also sometimes we get people where they just involve a doctor and they think, well, that's someone who knows about medical workforce, medical education. And that obviously just isn't the case, is it? Otherwise, medical education wouldn't be in such a state, would it? So make sure people really understand about selection, workforce, and domain expertise in that area. So anyway, just in terms of resources, just finish with, do try and get external funding. Take opportunities to build in academic trainees into the project if you can. Do get institutional support in writing, and don't just give vague statements, say, you know, this person will do it as part of their institutional role. And also in terms of dissemination, try and get, we've published it already. We've had a communication accepted for Amy, and we're reporting it back to NHS England, which has gobbled up HE, obviously. So be realistic about target journals, allow for article processing charge, things about the stakeholders who want to know about your results. Consider a pathway to impact. Make your code available, because we can't make the data available, but make your code available publicly if you can. And consider a pre-review service like medRxiv. And don't just say, give vague statements like, well, we often see, oh, we'll publish it in a high impact but journal like BMJ, like, you know, it's often, you can't, I've published at least one stuff in BMJ for UKMED, but it's not common. And don't wait years to write up because it goes stale. So anyway, just to finish off and summarize, focus on research worth doing and research that is doable. Keep the analysis focused on policy relevant questions, and don't apply unless you've got the right team, the right resources, and also don't let your findings go cold and stale or become a well-kept secret, because as Chris McManus reminds me, an unpublished paper has zero impact. So that's it. All in 15 minutes, I think. Stop the clock.
Well done. Thank you so much, Paul and Jane. So yeah, please do put your questions on Slido. We've got some already, which I'll put to you if that's okay. So Paul, would you be able to give an idea of the timeline for that project? Which is, how long did it take to get ethics approval, organize data extraction, analysis, etc.?
Well, Daniel Smith, who was the senior data manager until some point last year, assures me I have the fastest lead time of anybody who's ever used UKMED in the point of application to the point of publication. And I think that one, probably from the point we applied for the data to publication, was probably somewhere about 20 months. And that is as fast as it gets. And one of the, as Jane probably knows as well, it can take quite a while to get the data extract. So I think the lead time when I left, I don't know, you might know better, Jane. I think the lead time when I left for applying, having it approved by the research group and so on, to actually getting the data probably was somewhere like about 8 months. Is it still about 8 or 9 months minimum?
It got a bit longer and it's now coming back down again.
Yeah. I think because of various staffing changes, so I think it went up, didn't it? But it was at one point around 6 months, and I think it went up, to quite a long time, and it's gone down again.
But I think the good news is that with the recent staffing changes, the GMC have actually allocated more data analysts, and so they're working on addressing the issues. They previously only had one person, and it was it turned into a single point of failure when UKMED became very active. So now they've put more people in to do it.
Right, okay. So if I wanted to do a PhD with UKMED, would I need to get funding from NIHR, or is it possible to get funding from UKMED?
Well, Jane.
Funding from UKMED, sadly, no.
Yeah.
So you need to get your funding from elsewhere. However, we've been working with NIHR and also with other potential research funders to see if they'll prioritise us. And so the recent, there's been a recent call for medical education research, which specifically mentions that people with an interest in UKMED ought to be thinking of applying. So I think that door is open. We're pushing, but still you've got to find external funding.
Yeah, I would say as well, because I've got one externally funded student. I'm not my NHR funded PhD student, another one, and there he's doing most of it around UKMED, but he applied even before he started registering for his studies because of the long lead time. So if people are thinking of doing a PhD funded or otherwise, I would definitely get the application for data extraction in even as soon as you can, because once you get obviously register for a PhD, the clock's ticking.
So you can put in your UKMED application when under that funding bit, I'm applying for funding from NIHR for this. And
yeah, you can. Obviously, there's a problem if you didn't get funded, then you'd be left maybe struggling to do the project. But I think, to be honest, I couldn't emphasize more. It's really important to try and put an application in earlier, because you don't want to be waiting for a data extract for 10 months when you've got a PhD ticking away.
yeah, thank you. Okay. If I wanted to do some research with UKMED, how would I find someone to work with on a project? Is there a list of available projects somewhere? Interesting question.
Before they've started, there is a list on the website. I would have thought the best thing to do would be to contact the research committee.
You could contact the research subgroup committee, but the other strategy is, because all the accepted applications are public. I think there's over 200 of them now on the UKMED website, and also there's also links to published papers as well, isn't there? Usually,
yeah.
So probably your best bet might be to look at who's published from UKMED, and see if there's a group or team that's doing something you're interested in. Maybe reach out to them. I think that might be the best strategy. Because like I say, people usually put in their own data extract applications, but if you want researchers to collaborate with, just look at who's published what. I think is probably the best advice.
And I think one of the things to make sure about is that you have a high level of data analyst input and statistical support, because very often what people do who are clinicians is, we think we can do everything, and we put in a naive and unrealistic bid, having spoken on the telephone to the stats person at the local university. And actually you need to have more comprehensive statistical support than that to be able to get the project to fruition.
Hey, thank you so much for a really interesting and useful session. Give you a round of applause. That's great, thank you. So we've got the next speaker will be coming in and joining us in a moment.